Okay, hi everyone. Um, I think I'm going to just very, very briefly go through an overview of all the questions as a reminder, and then I'll let Dr. Antich do hers. So, okay, you guys can see that PowerPoint?
Yeah.
Okay, so these were the questions along with a general what % of people got each question correct and what the correct answers were, just as a review. So the two toughest were probably the bladder biopsy given by Dr. Antich and the placenta given by Dr. Hussein. We will go through each of these individually, but just to let you know, the answers will be available for you guys. There were some issues that recurred, some incorrect problems. So as we go through each question, I will bring up the most common diagnostic dilemma. Just as a review, these were the scores over time, which, generally people in PGY1 score similarly, 2, 3, 4, etc. And then if you want, we can go through the average scores per year over time, but essentially, I just wanted to get you guys some data. But first, let's do the exam. All right, so Dr. Antich, you have two questions. Do you want me to drive it? Do you want to drive it? Do you want me to give you remote control?
I can drive if you give me control.
Okay, so, okay. So if you just, this is your question, and then the next slide is the H&E, and then the following slides are the IHC.
Okay, let's see if I can.
Yeah, this is just an overview of the question. So 54-year-old male with urinary frequency undergoing bladder biopsy. So click on the left, click on 2.
Okay.
And that'll be the, yep, that'll be the slide.
Okay. I'm sorry that it was so difficult. I didn't expect it to be so difficult, but I think it's, I'm just wondering what people were answering, because I thought that the specimen itself is not going to be so difficult. Anyway, it's obviously that she has chronic issues, chronic inflammation of her bladder and chronic issues with her bladder. And that's something that when we think about these chronic problems like stones and inflammation, that we need to think about other things than just cancer, yeah? And most of the time in a bladder, we are dealing with metaplasias. When you have indwelling catheter, stones, chronic inflammation, then you are thinking about metaplasias. Why do we have metaplasia? Because the urothelium wants to be replaced by something tougher. And we often see in that case that urothelium undergoes either squamous metaplasia or undergoes mucinous metaplasia, and in this case is nephrogenic metaplasia. Now with nephrogenic metaplasia is problem that it can mimic many things. For example, this particular one has a papillary architecture, and you can, nephrogenic metaplasia can come either as a papillary, as a tubular. Therefore, you need to kind of think out of box. Like not everything that looks papillary to you, it's papillary urothelial carcinoma. Now, what's difference between nephrogenic metaplasia and papillary urothelial carcinoma? If you really look at the lining, you actually notice that there's only one cell lining. It's not like lots of thick urothelium that you see with urothelial carcinoma. This is mostly one cell lining. The cells itself have somewhat hobnail appearance, and the nuclei quite blandish, as a matter of fact, with maybe hint of small nucleoli. Therefore, you have papillary architecture, one cell lining, and hobnailing in this very inflamed bladder. And that needs to prompt you to think about nephrogenic metaplasia. You might say, but here is more. This is because it's probably cut tangentially, and that's why you see multiple layers of cells. Now, I had a case. I've seen cases where people call this, let's say, in a prostatic urethra, that people call this prostatic adenocarcinoma because they look like glands or tubules, and they look infiltrative. And you need to keep in mind that nephrogenic metaplasia can be really deceiving. Now, there's a few things that can help you. You can stain nephrogenic metaplasia, and interestingly, just by name, it stains for PAX8, which is unusual for anything in a urothelium to stain with PAX8. Therefore, if you would like to confirm that this is nephrogenic metaplasia, you can actually do PAX8. Now, be careful if you're doing other markers like racemase or PSA, because sometimes nephrogenic metaplasia can be positive for those. Nephrogenic metaplasia is also positive for GATA3. Therefore, there is a way to actually correctly diagnose this in a patient that has chronic problems with bladder. And I think that's for this case.
Cool. So thank you. Most of the answers were either just a non-generic, chronic cystitis without mention of the metaplasia. But I did want to ask you, there were also some answers that were nephrogenic adenoma. So I gave that partial credit, but would you consider that a right or a wrong answer?
Actually, that's a correct answer. Nephrogenic, it used to be called nephrogenic adenoma because people thought that this is neoplastic process.
Okay.
And now we know that this is actually metaplasia rather than neoplastic process, and therefore I personally like to call nephrogenic metaplasia rather than adenoma.
Okay, so for the people that ended up saying adenoma, I'll give them full credit then.
Okay.
Okay, cool. Thank you. I think you have, is there any questions? I think you had another one down with the prostate. I think it's at the end.
I think so.
Keep going, keep going. Keep going, keep going, keep going. Yep, there it is, slide 30.
This
Slide.
one? No.
Yeah, slide 30.
30.
Slide, go up,
Go up.
go back up. I mean, it's actually, it's labeled slide, go up, go up, go up. Yeah, it's labeled 25, but it says slide 30 for some reason.
Okay.
Yeah, I think this is yours. 71-year-old male prostate biopsy. Yeah. So then click on 26, and that'll be the actual virtual slide.
Okay.
Yeah, perfect.
It's just one of those usual prostate biopsies, kind of boring, and you're just going through them and looking, of course, for what is always there. It's either benign or malignant, which is adenocarcinoma. And of course, in older patients and even with the younger patients with prominent BPH, peripheral zone is often atrophic, and you can see in here how glands irregularly shaped, and they have very thin layer of epithelium. Therefore, this is mostly atrophy. And then you just go along. Let me see, I think I got lost. Let me click again. Oh, am I wrong again?
Go back up to 26.
Yeah.
There.
And just by reviewing all parts as you would do, and you also review a periphery, and sometimes you also have colon mucosa. You are cruising along, you can see some fat, which is from extraprostatic space. you come to this interesting vessel, or at least it was very interesting to me, because the wall of this vessel is replaced by this amorphous pink material or purplish material, which doesn't quite look like normal vessel, at least I thought. And I decided to stain this with Congo red because it reminded me of material, reminded me of amyloid, which actually stained nicely with Congo red, and it was it has oh my God, what's wrong with me? Birefringent
Green.
green. Thank you. It's too early. Anyway, this was actually amyloidosis. I haven't checked what happened later with this patient, but I'm just going to remind you that every single piece of prostate and colonic mucosa needs to be actually looked at, because you never know what you're going to find. Now, regarding amyloidosis, in the prostate itself, you can have localized amyloidosis of the seminal vesicle and ejaculatory ducts, which is entirely normal process. We see that very frequently, and we do not actually pay attention to that, because this doesn't mean that the patient has some generalized amyloidosis. I do report it just in a case, but usually you don't see amyloidosis anywhere else in a prostate. Recently, I did have a case of prostatic stromal amyloidosis that I sent for typing, which actually had amyloid alpha, is it called like that? Mayo actually typed it, and that patient underwent, because that's not the normal component of the prostatic tissue and stroma, this patient actually underwent entire workup for generalized amyloidosis. They didn't find anything, but this was extremely unusual case of prostatic stromal amyloidosis. Therefore, even boring prostate biopsies can have significant findings, and therefore everything needs to be examined carefully. Any questions?
Thank you. I think the main issues here were probably, I think either people didn't see the strange material around the vessel or didn't look at that fragment. And so people sort of started guessing things like pin, order a pin 4 stain. So yeah, I guess, my curiosity, which I guess you already answered, was what clinical impact would finding this have? And so you may discover an incidental, amyloid related disease that you may not otherwise have known about.
Exactly.
Okay. Cool. Thank you.
Thank you, guys.
Mm-hmm.
So if I could ask a quick question, Tatiana, how often do you find this?
This was the first time I found in a prostate biopsy.
How about in a prostatectomy then?
As I said, in the localized amyloidosis around the ejaculatory ducts and seminal vesicles, frequently.
I see.
Frequently.
But not vessels.
But not the vessels.
I
now,
see.
as I said, this specific case of that almost like amyloidoma in a prostatic stroma, that is also extremely rare. I
Okay.
only have one case of that.
Okay. Okay. Thanks.
Okay, thank you. Let's see, who do we have next? Who's on here? We have Lindsay Yassan, Anna Birnaka, obviously we have Alia Hussein. Which one of you guys would like to go next? Does anybody have anything?
I can go next.
Okay. So yours was another challenging one. Let me get to it and then I can give you.
No,
want me to give you
I'm on my
control?
phone. Why don't you
Oh,
control it, please?
I'll control it.
Thanks.
Okay.
Yes,
So the
please.
patient is a 21-year-old female at 20 weeks, 3 days gestation, undergoing vaginal delivery for intrauterine fetal demise. What is the best diagnosis? So here is the slide.
Okay,
And
so
just
what did they say?
a lot of people actually said some hydropic type of molar picture.
Okay,
A few
Okay.
people did get the correct. Yeah. Mhm.
a few did. Okay.
Mhm, mhm.
So for the residents, I think the first thing you have to recognize is that it is really abnormal looking. That it is true that there's some villi look bigger and some villi are smaller. So your differential is actually appropriate, that it could be a molar, I don't know, there's no trophoblastic proliferation. So, and there are still obviously vessels. So it's obviously not a complete mole, but for a partial mole, those things are not big enough. They're just, right. So there's just a few. So what makes you think of an infection? So first, a second trimester stillbirth, you should think of something really severe that would be doing it. So the main things would be chronic villitis, but it is still kind of early for it. Usually chronic villitis could present a little bit later than this, but it could be, I mean, 20 weeks it could be. And so when you're looking at it, look at when you see variation, you should go down. So this is a higher power diagnosis. You should just go down and start looking around. So like here, as Nicole is showing, some of these villi are rather cellular. Then you'll say, okay, well, what is making it cellular? Then you go down and you say, okay, it's a mixture of lymphocytes and plasma cells, especially that, yeah, that one. Can we go a little higher on it? Can you see that there are plasma cells in there? Yeah. No, some look like stromal cells, some look like some lymphocytes. It certainly is very cellular. So, and then where are others that are not that cellular? If you compare them to those, some look edematous, as you noted. And even there, though, there are a few lymphocytes, so it's not totally degenerated. Then when you start looking at the fetal blood vessels, that's where the inclusions are in this case for CMV. And that's the most common place to find them, or like here. So if you could stay here. So anytime you find chronic inflammation, you must look for CMV inclusions, because those you can see on H&E. So you do have to look higher power, move around, and then find them. So in this case, there are obviously some very classic ones like that one, the inclusion on the left, but the one on the right that says this brighter pink, you should embed that image in your mind, this sort of granular pinkish material that almost in some areas looked like the cell was degenerating. But those are the inclusions that are mature and the cell will rupture and the inclusions will get released. You see those, and that should also make you think of CMV. And not only just in the placenta, you can see that in many settings. The pink sort of granular, it's cytoplasmic, right over there. See, oh yeah, Nicole, that was a great one. Can you go higher power? So see the one at the right at the top, the sort of, or even here too, right? So both of those, yes, you are just seeing this material sort of free floating almost as the cell has ruptured. And there's also apoptotic debris next close by. So you are thinking, okay, the fetus has died, you will get apoptosis, but you should remember what CMV looks like in different phrases. So this is a case you should then go back to on your own, look around, go to different areas, go at high power, kind of put in your mind how CMV looks. It is not a very common diagnosis, but it is diagnostic, and the mother probably may need to be treated. Yes, that. So all of that fragmented blue-pink material should make you think of CMV. And then when you go around, you'll find the classic inclusions.
Yeah,
So
it's like, as we were looking at it earlier, it's like once you see one, you start seeing a lot.
Yes, yeah. So if you don't, the other thing is if you don't think about these things, it doesn't come to mind. So now that you know what CMV can look like, we see it probably once a year or so. here once every, yeah, or I see it once a
Is
year.
this karyorectic debris, is this like a clue, or can you see this kind of stuff in other?
You can see it in any IUFD.
Okay.
Because when the baby dies, the vessels become apoptotic and the cells especially start fragmenting. And that's you can see with just for any cause.
I see.
Yeah. And the edema is probably because the baby had CMV for a while, and
I see.
who knows. Okay, but the IHC was spectacular. It shows so many inclusions there. So, yeah. Even when you don't quite see inclusions, anytime, so the time to order a CMV stain is anytime you see chronic inflammation with plasma cells. The velitis of unknown etiology, which is thought to be immune reaction against the paternal antigens in the placenta, usually does not have plasma cells. So the clue for both CMV and syphilis are plasma cells.
Okay.
Okay.
Awesome. Does anybody have questions? Okay. Who would like to go next?
I can go. This is
Okay.
Lindsay Gasson.
Okay. Do you want me to give you control?
Sure, we can try that.
Okay. It was this one, right?
Yes, this is the case.
Okay. Remote controlled. Let me give it to you. All right.
Okay, it seems like I have control. So this was question 3, 67-year-old female with esophageal plaques undergoing biopsy. So for this one, it was nice because we also had a corresponding endoscopic image. So from here, you can see that we have this yellow raised plaque-like lesion within the esophagus that was biopsied. And here's just a closer up view of that. It almost has like a somewhat cauliflower appearance. And then this was the slide. Very small lesion overall. So at relatively high power here, we can see that we have the background squamous mucosa of the esophagus. And then what it's remarkable for are all of these relatively bland cells with cleared out cytoplasm. And as you go higher power on these cells, we can see that they have almost centrally located nuclei, and then they're filled with these vacuoles, which have more of an optically clear tinge to them. At higher power, you can really appreciate that they almost also have like an optically clear bubbly appearance to it. So this is sebaceous cells within the esophagus. It's a very benign condition. It's kind of more of a fun diagnosis than anything. I think a lot of people also put xanthoma on their differential, which is a really good differential to keep in mind. Usually in terms of xanthoma, they could endoscopically have a very similar appearance, kind of a yellowish lesion. In terms of the cytoplasm, it's also relatively pale compared to the background. However, the cytoplasm isn't necessarily and not usually optically clear. It's more of a foamy cytoplasm. So the differential between these two is more H&E based than anything. And it's not this optically clear vacuolated cytoplasm that we have in this case. They're both benign conditions, however. And if you wanted to differentiate between the two, you could do like a CD68 or CD163 immunostain to be more confident in your diagnosis. I have one PowerPoint slide I can share.
Yeah.
If that makes it easier. Hold on, I'm just gonna pull up my slide here.
I've stopped, so hopefully you could start.
Okay. Hold on for 1 second.
No
I'm not
worries.
as I'm not as good as this as other people. Let's see.
Yep.
Okay, perfect. I'm just going to keep it on this view. I know it's not the ideal view. But in terms of esophageal sebaceous glands, it's unknown if it's an ectopic or metaplastic origin. A metaplastic origin is favored. Oh, hold on for 1 second. Thank you so much. Sorry. So in terms of esophageal sebaceous glands, it's unknown if it's ectopic or metaplastic. Most people favor, though, that it's a metaplastic origin because of the embryonal germ cell layers. So because the esophagus is derived from endoderm, most people favor that it's actually metaplastic change. And that it may occur in kind of the benign mucinous glands that we sometimes see in the esophagus. Most are discovered incidentally during endoscopy, and that we only usually see these in adults, usually ages like 40 to 70, and it's really not seen in children. And this has been confirmed by autopsy findings. And because of this, it's also favored that it's more of a metaplastic origin rather than an ectopic origin. In terms of the endoscopic appearance, it's very classic how we have in our case, yellow, tan, various shapes, and the number of lesions can vary from 1 to more than 100, as we have it. The case that is highlighted here on the right with all of these lesions throughout the esophagus. And then in terms of the significance for clinical management, there's really no significance. They're asymptomatic, benign. There's no need for treatment. Based on the studies we have, the lesions are typically stable on follow-up, and no malignant change has been reported thus far in these lesions. I
Cool.
can stop the sharing, and if there's any questions, I can answer those now or later, whatever is easiest.
Awesome. Thank you. Anybody have any questions? Okay. Dr. Birnaka, would you like to
Yes.
go next?
Yes, I'm here.
Okay, then let me pull up yours. Here it is. Do you want me to give you control or do you want me to drive it?
Let's try. I can try to drive.
Okay, let me hand it over to you. So this is just the question stem for a 64-year-old female with recurrent right-sided breast cancer, now undergoing bilateral mastectomy. And what you've provided is from the left sort of prophylactic mastectomy. So the next slide is actually going to be the better quality. So if you go to 21.
21, okay.
Yep, there it is.
All right, so I put out the slide because it has a couple of diagnoses, a couple benign and a couple low grade. And diagnosis, as frequently in breast pathology, we have to list more than one thing. This is, as you said, is prophylactic. Her other side had invasive lobular carcinoma as well as lobular carcinoma in situ. And in this slide from her contralateral breast, the most eye-catching lesion is this lesion. That is lobular carcinoma in situ classic type. So I think that low power, it's very helpful in recognizing lobular neoplasia when you have expansion of terminal duct lobular units, frequently with this more white and loose stroma around the glands. On the higher power, you can recognize LCIS cells as a very monotonous, low-grade appearing cells with round nuclei, very evenly distributed chromatin, sometimes small nucleoli, more peripherally located. And the key for diagnosis is a cytoplasm of those cells that is light pink or pale with cytoplasmic lumens, like here, or this bubbliness. And overall, maybe not in this focus that much, but overall kind of discohesive appearance of the cells that is the underlying molecular feature of lobular neoplasia. It's a lack of ecadherin, that is cell adhesion molecule. So that's why lobular processes are characterized by discohesive nature. And you can have some lumens in lobular carcinoma in situ. However, they are like secondary lumens, and the cells won't polarize around those lumens. And there are multiple foci like this in this slide. So it already, I think, easily brings you to the diagnosis of lobular carcinoma in situ classic type. I should mention it's classic type because of the nature and of the cells. They are not pleomorphic. But if you have a similar lesion with lesser extent, the diagnosis would be a typical lobular hyperplasia. The other lesion that is present, let me zoom out. And here, is here, okay. Okay, so this is another lesion that belongs to the ER positive low-grade neoplasia pathway in breast pathology. This is also composed of kind of similar cells to me that we just saw before. They are very monotonous. In this case, maybe they are a little more evenly distributed. But overall, they look similar. What is different about them that they do polarize around the lumens, and they form those here slit-like spaces, but they can form cribriform spaces or papillary formations. So this is ADH. And it's exactly the same process as low-grade ductal carcinoma in situ, just not that well developed, just smaller. In this case, it's definitely less than 2 millimeters. That is a cutoff for diagnosis of low-grade DCIS. It's partially involving the duct because you can see like the residual lesion is maybe like a small duct papilloma or in some benign proliferation. But in this area, it's involved by the monotonous proliferation that is ADH with cells polarizing to the lumens. And this lesion will be negative for CK56. I think it's very reasonable to order it in this case. So negative for CK56 of CK514 and diffusely positive for ER, and they will be expressing membranous ecadherin. In contrast to lobular carcinoma in situ, that will be negative for ecadherin, but it will be also strongly positive for ER, and it will be also negative for high molecular weight cytokeratins like 5-6. So seeing those lesions, it should prompt you to look for associated low-grade invasive carcinoma because she is at the higher risk of having associated invasion. That's why I hope that you look around and seeing some other areas that I'm trying to find, and I can't right now. Let me zoom out. Oh, here. So, you know, definitely here your differential would be low-grade ductal carcinoma, low-grade invasive ductal carcinoma, that would fit, you know, with the presence of other lesions like ADH, LCIS. But here, when you look closer, even though they are tubules, you still can recognize like pink colors of collagen around them, and even myoepithelial cells present around them. At the lower power, they still have somewhat organized arrangement. That this is not a infiltrative pattern. It's yeah, you don't see desmoplasia. So this is sclerosing adenosis that can be like here. I think it's starting to happen here. There is LCIS crawling into sclerosing adenosis. So it can make it even more difficult because you can have LCIS secondarily involving sclerosing adenosis that may fool you that it's actually invasive lobular carcinoma, but myoepithelial markers will solve those dilemma. And there is one more lesion present here that is very subtle, and hopefully I will be able to find it. We like this lesion in breast pathology. It's not that important because it doesn't have any risk associated with it. It's not here. Nicole found it when I saw.
You want me to try to find it again?
Yeah, let's find it.
I think here, I'm gonna take control for a second. I think it might be somewhere over here.
Oh, maybe, yeah, on this side. Yeah, exactly.
Is it
Yeah.
on this side?
Yeah, I think it's on this side. Yeah. So let's zoom in here. Oh, I saw it. I
You
think.
saw it? You saw it?
Yeah, yeah, yeah.
There you
I
go.
saw it. Okay. Here.
Oh, yeah, yeah,
Yeah, we always get excited when we see it.
yeah.
So it's collagenous spherulosis. It's it has very like typical. This one has a very typical look with this eosinophilic cylinders of basement material present. It's a benign lesion that occurs in association with other lesions like intraductal papillomas or sclerosing adenosis, and is I don't know exactly how it develops, but if you stain it with myoepithelial cells, you will see the myoeps actually surrounding each of these cylinders and also being present at the periphery. And the
So
differential
it's kind of like adenoid cystic.
yeah, exactly. It's also differential cells adenoid cystic of the breast, and it may become a little more difficult. Like, for example, in this case, we have associated LCIS. If you imagine like this lesion being colonized by LCIS cells, it will become more cellular and you will have those monotonous cells, but this overt cribriform appearance. So there are case reports of it being misdiagnosed as ductal carcinoma in situ cribriform type. Then that the management is different, right? Versus like being globular, you don't do much, you don't re-excise margins, and if it's misdiagnosed as DCIS, it may influence the management. So yeah, be careful, and ECAT hearing will solve this for you. That it will be ECAT hearing negative in case of colonization by LCIS and positive if indeed it is DCIS. Okay.
Thank you. So yeah, some of the issues that came up were some people did diagnose invasive carcinoma. I assume probably in those sclerosing adenosis areas. So just to reconfirm on this slide, there is no invasive carcinoma.
Yeah, there's no invasive, and maybe it was a little unfair because as I know this case, of course, I did my epithelial
Yeah,
markers because there are several areas that look, funny.
right.
And
So then some people also said a microglandular adenosis instead of sclerosing adenosis. What, is there a conceptual difference there?
Yes, I would say that in microglandular adenosis, you will have like more open glands.
Mm,
Then as in sclerosing adenosis, they're more compressed and um, mm, distorted. In
okay,
microglandular adenosis, they have more infiltrative pattern, they're more open, they have the eosinophilic material in them,
mhm,
and this is like morphologically. And then by immunohistochemistry, sclerosing adenosis will have myoepithelial markers versus my microglandular adenosis will not have myoepithelial cells and expression of myoepithelial markers that brings, another problems in the
mhm, mhm.
differential diagnosis. But I think that I would forgive those people that may diagnose, the low-grade invasive lobular or
Yeah,
ductal invasive carcinoma, because that is what they should be on the look for.
right, right, right.
Maybe not to fire out the diagnosis, but be like diligent to look for it and then order myoepithelial markers to rule in or out.
Right, right. Okay.
Okay.
Excellent. Thank you. Does anybody have any questions? Okay. Are there any other other people, or are the rest of them? Oh, is Jenny here?
Yeah, I'm here.
Okay. Do you want to do yours?
Sure.
All right. 71-year-old female with pelvic mass undergoing core biopsy. Do you want me to give you control?
That's fine.
All right. Let me search for you. There you are. Okay.
Okay, so I put this case out because it's a diagnosis that we don't typically see in a pelvic mass on biopsy, since the majority of them are all high-grade serous that we get. So we have multiple fragments of core biopsy tissue here, and you can see the background, it's very hyalinized. So that's already a clue to the diagnosis. And then we look at these cells. They have a tubular cystic growth pattern, and I think some also have more of a papillary growth, if I'm recollecting it correctly, remembering it correctly. Yeah, these are a little more papillary. And you have these cells, they're not exactly clear. They have more eosinophilic or an oxophilic cytoplasm. The cells look pretty monotonous all throughout. Some do have prominent nucleoli. There is a little bit of clearing in some of these too, and they have a little bit of a hobnail appearance. So this is actually clear cell carcinoma of the ovary. So definitely not a common finding you see on biopsy, but it is very helpful to hyalinize background. Other things you can see include a lymphoplasmacytic background, which isn't really seen in this case. They tend to arise in a background of either endometriosis or an adenofibroma. I'm not sure if we ever saw the resection from this case, but you couldn't see endometriosis or adenofibroma in this particular case. The tumor is generally positive for napsin A, which is a helpful diagnostic marker, since most other epithelial ovarian cancers are negative for napsin A. It should be negative for ER/PR, or at most very focally positive, which contrasts with an endometrioid carcinoma of the ovary, which should be strongly and diffusely positive for ER/PR, including the variant of endometrioid adenocarcinoma with clear cell change, which is definitely a diagnostic mimicker for clear cell carcinoma. HNF1 beta was originally taught it as a Greek stain to differentiate clear cell carcinoma from the other epithelial ovarian carcinomas, but lately it's been seeming that almost everything is staining for HNF1 beta, so it's not as helpful. About 10% of tumors do harbor P53 mutations, so you can have strong and diffuse P53 expression. So that shouldn't, if you see that, you shouldn't be dissuaded from the diagnosis of clear cell carcinoma and think that it's a serous. Also, P16 can be strongly and diffusely positive in a subset as well. So definitely when you have strong and diffuse P53 and P16, it can be very difficult to distinguish from a high-grade serous carcinoma. But normally the lack of ERPR positivity and positivity for for NAPSINA should be helpful. And of course, some morphology, because the nuclei are uniformly atypical, whereas in high-grade serous, they're very atypical and pleomorphic. And molecularly, about 50% harbor ARID1A mutations, which you also shouldn't see in high-grade serous carcinoma. So it's, we don't actually have ARID1A stain in HTRC, but we do have it in, no, we don't have it in our clinical lab, but we have it in HTRC. So it's actually a helpful marker if we wanted to do it on a research basis. Any questions?
I think most people, or a certain number of people said carcinoma at least. So I gave them partial credit. A few did get the correct diagnosis. And then there were just a kind of a couple other outliers. Like I think there was maybe an angiosarcoma. Maybe some people interpreted the material inside those as, you know, blood vessels or something.
So, Jenny, if I could ask quickly, so on a frozen section, I mean, that's why when I see most of these is, how important is it to tell them exactly what kind is it? Because I don't know that I would be able to recognize this as a clear cell carcinoma.
Right, because it's more oxyphilic.
Yes.
No, it's really just high-grade carcinoma. As long as they know it's an epithelial ovarian carcinoma, they'll go ahead and stage the patient.
Okay, thanks.
Awesome. All right, I'm gonna get control back. I don't know what I just did. Let me get rid of my calendar. Okay. Okay, anybody else have questions? All right. Is there anything else now, or is now the rest just me? And I'm gonna talk about Krause's. All right, it's just me. So this guy was this woman was a 19-year-old with a right thigh mass undergoing resection. So we have a gross image and a microscopic image. And so, ooh, full screen. That's nice. Let me see if that, great. Okay. So the cut surface of this mass seems to be kind of orangish yellow and relatively homogeneous. And so when you know, hopefully you appreciated that this is the appearance of perhaps fat, but it's maybe a little more, you know, orangey brown as opposed to bright yellow of regular fat. And as I said, it's also quite homogeneous. You know, there are a few specks of blood here and there, but that's perhaps just some intralesional vessels. And so all right, let me get out of here. So when you look at the microscopic slide, you can perhaps appreciate that it's a little more busy than just plain mature fat lipoma. And so if you look at the busyness that's going on in this fat, you'll notice that there are some that are more classic mature open fat vacuoles, or fat cells that have a univacuole. However, a number of the cells have multiple sort of small vacuoles, and these multiple small vacuoles very, very, very crucially do not indent the nucleus. And so the nucleus here of these fat cells is plump and open, and has maybe a small nucleolus. And so if you look around, you can see that that's generally the case. So I'm going to point out, here's an open nucleus, an open nucleus, an open nucleus that's not indented, a nucleus that's not indented. And so you can see that there's heterogeneity in the number, density, and kind of eosinophilia of these vacuoles. And so this is brown fat. Okay, so this is brown fat. These are not lipoblasts because there are multiple vacuoles that do not indent the nucleus. And so this is, in fact, a hibernoma. And so you can get any benign adipocytic tumor that has any amount of brown fat in it, you can call a hibernoma, even if the brown fat is focal, because in a mature conventional lipoma, you should really not have any brown fat whatsoever. And so there are, there are hibernomas that are 100% brown fat, and there are hibernomas that are, 99% mature fat and 1% brown fat. And those would be the so-called lipoma-like hibernomas. In this case, there's a pretty good admixture of about, half mature fat and half brown fat. But the important thing to remember is that this is just brown fat. These are not lipoblasts, and therefore this is not a liposarcoma. This is a hibernoma. And again, this kind of brownish, tannish color, orangish color is indicative, again, of what you see microscopically. Do you guys have questions on that one? Okay. While we're on fat, I'm actually just going to skip to the end one. This was Dr. Krause's case. So 66-year-old female with pelvic mass. What is the best diagnosis and what stain would support? So you can see here that whatever this mass is sort of abutting or involving, at least adjacent to the colon, with a little bit of adjacent to the fallopian tube. And where's the cut surface is no longer homogeneous, right? It's very heterogeneous. It's very opaque looking, right? There obviously there's some areas that are more fixed, which is more brown, and some areas which are less fixed, which is more pink. But in the center here is this very opaque, very dark brown area. There are patches of more gelatinous looking tissue. There are patches of more solid white or looking tissue. So this is, already much more worrisome for a malignancy than that, very homogeneous hibernoma that we just saw. And so on microscopy, here's what we see. So again, we see cells that have vacuolated fat. And I think the most common issue here was in the subtyping. I think most people understood that this was some kind of sarcoma. I think most people understood that this was perhaps some kind of liposarcoma. And if you are in the abdomen / retroperitoneum, this should guide your thought process. So number one, if you know you're in the colon or you're near the colon, right? The colon is essentially a retroperitoneal organ. There's only peritoneal surface on the right, at least the right and left sides of the colon, right, are retroperitoneal. And so I'm not entirely certain what section of the colon this is coming from. I apologize. Obviously, this is not the full colon. This is relatively distal and relatively proximal. But anywhere in the abdomen or retroperitoneum, you should really, really, really be thinking, number one, well-diff, D-diff, liposarc. Number two, well-diff, D-diff, liposarc. Number three, number four, number five, number six, number seven, number 8, number 9, and number 10. If it's a fatty tumor, well-diff, D-diff. So how do you make those distinctions and those diagnoses, and why? So first of all, you see that you have mature fat, and you also have these cells with multiple vacuoles. But in this case, the vacuole is indenting the nucleus here. Okay, so that's thing one to make you suspect. Oh, here's a great one, that these are actually lipoblasts instead of brown fat, for example. And every single cell where you have an indenting of the nucleus, that is okay for a lipoblast. Secondly, you have this myxoid background with occasional highly atypical cells. And this pattern of low kind of, intermediate power, where you start seeing these cells pop up here and there, those are, that's significant nuclear pleomorphism. And when you see these cells pop out here and there, in a background of an otherwise sort of paucy cellular specimen, you certainly want to think about a well-differentiated liposarcoma. And so in the retroperitoneum, your primary type of liposarc is going to be well-diff with or without a transition to D-diff. If you're thinking myxoid, because of the myxoid background, if you're thinking pleomorphic, because of those somewhat pleomorphic lipoblasts, in the retroperitoneum / abdomen, those are diagnoses of exclusion, and those would inevitably be metastases from myxoid liposarcomas or pleomorphic liposarcomas of the extremity. Those types of liposarcomas do not primarily arise in the retroperitoneum. So if there's anything I can teach you, please, 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 before you diagnose any liposarcoma in the retroperitoneum, think well-diff, D-diff, and do your MDM2 either by immunohistochemistry or molecular. So MDM2, CDK4, and chromosome 12 would be amplified. So you would see expression in the nucleus of these tumors. So that's point one. So then you know it's on the well-diff, D-diff spectrum. So point two is, in order to get from well-diff to D-diff, you need hypercellularity and mitoses that are in excess of 5 essentially per 10 high power fields. And so in this case, I don't really see much hypercellularity, and we don't really see many mitoses. So we are still on the well-diff side of the spectrum. You can have myxoid liposarcoma like well-diff liposarcs. You could have pleomorphic liposarcoma like retroperitoneal well-diff, D-diff liposarcs. Okay, so these can mimic each other very much, but always remember that the MDM2 amplification is going to be your discriminator, and the site of the retroperitoneum is going to be your discriminator. And so if you do not find MDM2 amplification in a retroperitoneal fatty tumor, then you can think about an alternate diagnosis. Until then, your top 10 answers are well-diff, D-diff. Does that make sense? I saw something in the chat. Okay. All right. Does anybody have questions on that one? Okay, it's 9:01. Sorry, I'll get through the other two quickly. So, yep, done. Okay, this one. 76-year-old female with maxillary sinus lesion, endoscopic sinus surgery. Frozen section is requested. What is the best diagnosis? And bonus question, what is molecular? So actually, I think a lot of people ended up getting this one. So well done. If you listened to my lectures or read the PowerPoints. So this is not an uncommon question on frozen section for endoscopic sinus surgery, chronic sinusitis, either with patients with a known history sometimes, or sometimes patients without a known history. But what you see are these very voluptuous, voluminous, I would say, anastomosing and architecturally complex channels of thick epithelium in a background of a somewhat edematous, almost one might consider inflammatory polyp type of situation. But even if you are on the background of what you think might be an inflammatory sinonasal polyp, once you start seeing this amount of epithelial proliferation with invagination and downward growth into the stroma, then you start to look at the epithelium, and the epithelium looks stratified. The nuclei end up actually not being oriented, horizontally. They're kind of oriented vertically, giving them almost a urothelial or a transitional-like appearance. And there's a surface covering with these respiratory epithelial columnar type cells. And there's intraepithelial neutrophils, and occasionally intraepithelial neutrophilic microabscesses. And so this is essentially diagnostic of, there's a nice one right there, of a sinonasal papilloma, formerly called Schneiderian papilloma. sometimes called inverted papilloma. These names have changed throughout the years, but I think most of you got some kind of sinonasal Schneiderian or inverted papilloma. A couple people, I think, called it oncocytic variant, which is incorrect. This is the conventional variant with this transitional type of epithelium. Oncocytic would be much more pink, and the epithelium ends up being much more tufted and actually oncocytic. So you know, that name is there for a reason. You would have much more eosinophilic cytoplasm and large nuclei with prominent nucleoli. So this is the conventional type. Don't, always submit these 100% for histology to rule out malignant transformation. And here's the permanent section of that lesion on a non-frozen slide, recapitulating those same features. And the molecular alteration in these are generally related to EGFR mutation. A small percentage of the inverted are related to low risk HPV. Most of them are EGFR, and the oncocytic are related to KRAS. So if you got the EGFR, you got an extra half point bonus. Anybody have questions? Okay.
So these are true neoplasms, is what
Yeah.
I did not know that. Okay.
Yeah, these are true neoplasms.
And do they become malignant?
Yes, the data says about 20%. In my limited experience, I think it is lower than 20%. We've only had, over the course of the past 10 years, that we've only seen like 2 cases transform, and we see quite a lot of these. But yes, they can transform to squamous cell carcinomas.
Okay.
Yeah.
So they become squamous. That was my next question.
Yeah.
They look the same.
Yeah, so they become essentially squamoid or squamous cell. So sometimes they transform to a very conventional keratinizing squamous cell carcinoma with conventional classic like infiltration. And sometimes they, the most recent case we had was not so much that. It was an actual more of a, sometimes people just refer to it as a Schneiderian carcinoma because it retains this broad-based invasion, but the epithelium is much more cytologically atypical, bad, high NC, shows mitotic figures, and it just deeply invades the sinuses, but it still retains this broad-based type of invasion rather than the nested infiltrative invasion of a conventional squame.
I see.
Yeah, so it can do either one of those 2 things, and they're both possible. But it's fascinating. Yeah.
And it still has the EGFR mutation?
Yeah. But it probably it might gain like P53 or something like that, right? But it should maintain the EGFR that it began with. Yeah.
Okay.
Yeah.
Nice.
Yeah.
So that's where you could differentiate it from a regular carcinoma then.
Right, exactly. Or if you see a background Schneiderian papilloma, or if you have EGFR, because conventional squames don't really have that. Right.
Nicole, once it invades, does it add any additional genetic stuff?
That's a good question. Maybe there's limited data. I'd have to look in the literature, but I assume it's probably compounded by additional P53 or other more high, additional mutations. I'm not completely aware that it's uniform. Transformation in these isn't necessarily a uniform genetic event. It's probably a hybrid of many things. So I'm not entirely sure, but that would be my guess. Yeah. But they do maintain, I think it has been shown. Aaron Udiger works on these. Remember, he came and spoke. So I'd have to check back on his papers. I'm not entirely sure.
Yeah, I remember the lecture.
Yeah. Okay. Anybody else? Okay, I think I have one more, right? Yeah, so this is a 77-year-old male with an enlarging thyroid mass, 11 centimeters, best diagnosis. So, old men with thyroid nodules should always raise your index of suspicion a little bit, because this patient population is at risk even more than an old female for example, for thyroid cancer. And in this, and the size of 11 centimeters, you know, this isn't 100%, but it should always raise your index of suspicion. Secondly, looking at this growth pattern of this gross image should highly, highly raise your suspicion for a malignancy, because it is multilobulated, it is heterogeneous, it is partially opaque and necrotic, it is partially hemorrhagic. And so any benign thyroid nodule, you really want to be able to maintain a border, right? Like you want to be able to draw a nice ovoid circle, and here you can't, right? There's a little satellite here. There is multiple heterogeneous areas. So already this gross impression should worry you. Lastly, on microscopy, the microscopic features recapitulate that gross kind of heterogeneity, not only in the architecture, but also in the necrosis and the hemorrhage. So one, let's look at the overall architecture on low power. And to me, your gross and your low power evaluation of a thyroid is crucial. So what do you see here? You see a little satellite nodule on the bottom, and then this larger thing that is already very, red, pink, blue, purple, right? So already very microscopically heterogeneous. You see another satellite nodule over here. Hopefully you can see my arrow pointing out these other very lobulated satellite nodules. So that is not really compatible with a benign diagnosis. This implies intrathyroidal invasion, okay? So sometimes our thyroid cancers don't perform those beautiful, like mushroom-shaped capsular invasive foci, right? Sometimes they're already out and they're already trying to travel. Sometimes the cap of the mushroom has just like amputated and is walking away from the stalk, right? So these little guys are all intrathyroidal invasive foci. So if you said that this was some kind of thyroid carcinoma, you at least got partial credit. If you identified the components of these cells as being very large and eosinophilic with kind of finely granular cytoplasm and large ovoid nuclei with very prominent nucleoli, and you called this an oncocytic or a Hürthle cell carcinoma, you got essentially full credit. So those were the two things I wanted you to be able to identify. The other thing here that could be a confounding factor is that there is all this hemorrhage and necrosis and neutrophilic inflammation in the center, which does anybody know why might this nodule, or what are a couple of reasons why this nodule might be so incredibly necrotic? So the two reasons are either this is intrinsic tumor necrosis, and this could be a poorly differentiated or an anaplastic type of carcinoma, or this is a Hürthle cell neoplasm, and we know the Hürthle cell neoplasms are incredibly sensitive to fine needle aspiration, and they infarct. And so this is probably because of the large zones of necrosis with preservation only of viable tumor at the periphery. This is probably FNA infarction. So you want to make sure the patient, in fact, has had an FNA. If you're thinking about poorly diff, usually the necrosis in poorly differentiated is more punctate. So you're going to see maybe like small little foci within the viable tumor rather than these giant zones. And so that's thing one. Thing two is the other way you can make a diagnosis of poorly differentiated is if you end up having numerous mitotic figures within a solid background. So you do see here that this is a solid or trabecular type of background without actual follicular lumina, but you'd still need to see 3 mitoses per 10 high power fields. And I think I didn't get to that. I only maybe saw 1. So, poorly diff would be a consideration, but I don't think it met that criteria because I don't think it maybe had 3 per 10. Maybe it does. There's a second one. No, that's just a scrunchie. Okay. So anyway, poorly diff would be a good consideration. I don't think this is true tumor necrosis. I think this is infarct necrosis, as I said. And lastly, it wouldn't be anaplastic because the morphology of these cells is still that of a thyroid follicle cell. And so once if you could still recognize this as a Hürthle cell, it isn't anaplastic. Like it has to be just, you can't even recognize that it's thyroid. It looks squamous, it looks sarcomatoid. Okay, so that's that. And I think there was a thing of maybe there was a medullary question. So sometimes oncocytes can maybe resemble C cells because of the granular cytoplasm, but honestly, C cells have much more of that neuroendocrine type of chromatin, which is salt and peppery, rather than this fine chromatin with these nucleoli. So the nuclear features could help you distinguish, but if you're concerned, you can just throw your calcitonin on and it should be negative. So that's this case. Does anybody have questions? Okay, I think we've done them all, right?
Yep.
Okay. I am happy to send out the link to this final presentation with all the IHCs and everything to the chiefs if you guys want to do whatever you want to do with it and put it in your, embed it in your file or send it out. If you have additional particular questions on how you did, just email me. But I think, everybody, is in the range, class range. But if you have particular questions, please just contact me directly.
Yeah, thanks. We can just take, if you just want to email us the slides, we can
Yep.
maybe just put it in a folder in the phone represents. All right, thanks everyone.
Yeah, thank you.